So actually it wasn't tricky, so I'm surprised actually. Maybe you didn't understand the question, but you have to be careful because some of this information is straightforward, but for some reason you missed the question. That wasn't anything difficult, I guess. So anybody can want to discuss this? Why he get it? About the growth plate?
What was the question?
No, there was a question about the growth plate.
The one last TBL, right?
In the TBL.
The growth
6% or one?
now,
Similar
the
definition.
one where
The
the
growth
growth
is just similar.
becomes bonus and you have percolation.
Yeah, it was the same rate.
Agree, and it
So-
doesn't change its thickness because it's keep
Yeah,
growing.
Yeah, but so I think if you hear this once from me and the question is nothing really confusing. I'm just want to see why is that 6%. In other words, like 170, another 80.
They didn't study, I think.
Yeah, but I mean because your overall performance was lower than the previous one, I think. You have to be careful. You shouldn't drop like this. Anyway, so today we'll be talking about the mineral homeostasis. We have 3 lectures today. Next week we have 2. So these are today's learning objectives. So I'll start with this case. This is a patient, 45-year-old woman, presented emergency after her thyroid surgery. 2 days after the surgery, she developed this numbness in the fingertips, muscle cramps, which is painful, and she also feels anxious, and she said her hand tightened suddenly, muscle contraction. Usually there's a test that you do, which you put this manometer, you raise the pressure, you cut the circulation, these people will develop cramps in muscle contraction. The main thing in the lab, look at her results. She had a total serum calcium low, ionized calcium is low, and her PTH is low. So we'll understand the case by discussing this, why calcium must be tightly controlled, how the parathyroid gland sends calcium, and how the PTH control this. This is a typical patient who's come after surgery with this, and she has hypocalcemia. The calcium really is low. And you develop this symptom because it increases the excitability of the nerves, so they have those tingling and numbness in the fingers, and also if you just put a little bit of pressure, cutting the blood a little bit, they get cramps. So typically this is because she removed also probably her parathyroid. This is the key here. Usually it's a common thing with the parathyroid removed when they remove the thyroid gland, and we'll see why. So we mentioned the function of the bone several times, and I show you this several times about the functions of the bone, mechanical structure, but the main thing that for the next few lectures is the storage of elements, especially calcium. So because of the function of the bone in controlling calcium, it is very, very tightly controlled. If you look at anybody readings and calcium level, if you look at anybody's lab result, and you look at the range for calcium, it's very small. The range is very, very tight. So it means that the body has to react quickly to fix any changes in the calcium level inside your circulation. So if you look at the total body calcium, we said before, the bone is the calcium storage. We have about 1 kilogram of calcium in the body, 1,000 grams. 99% exists in your skeleton. So basically all your calcium is in your skeleton in the form of the hydroxyapatite. We said the bone have 2 components, organic and inorganic. Organic is the collagen, and then inorganic is the hydroxyapatite, which is calcium mostly and some phosphate. 99% exist in the bone, calcium exists in this form. Only 1% exists in the rest of the body, in the blood, in the extracellular fluid, and soft tissues, and so on. Not only that, so look at this. This is the illustration showing you, it's terrible, just drag this thing all the way down. Can't move. So the bone, 99% of the calcium in the bone, 1% outside the bone. So here it is in the soft tissue. 1/10 of the 1% is in the extracellular fluid, and 90% of the 1% is in the cellular organelles. So it means 1,000, which is 1 gram, exists in the blood and the extracellular fluid. So this is just show how low this is. And this one, 0.1 of the 1%, which is 1,000 of the total, also divided into 2. What we call ionized calcium, which is the active form. This is what we hear, which is 50% or 55%, and then the rest is bound to something else, protein or can be complex. So it means half of this is the ionized calcium. So we're talking about 500 milligram only. is the ionized calcium that actually the whole body works to keep this under control. Everybody else, it doesn't matter. So very, very small amount of calcium is the active part of the calcium, which is ionized calcium that you need to tightly control. And also calcium is available on the diet. We don't make calcium in the body. So how's the regulation of the calcium? Why is that? Also because of the neurotransmission, muscle contraction, many of the functions, even muscle contractility, the heart depends on, because of the muscle contractility, you have to make sure that you control the calcium. And what regulates this is actually, we're talking about 3 hormones today, the parathyroid hormone, vitamin D, and calcitonin. These are the 3 main contributors to control of calcium level inside the body. And they target actually 3 organs: the intestine, the kidney, and the bone. So this lecture, next lecture, we'll be talking about the combination of this, how the PTH, the parathyroid hormone, and vitamin D and calcitonin control the calcium through acting on the intestine, the kidney, and the bone. So today we'll be focusing basically on the PTH. Next lecture will be more the vitamin D and calcitonin. So this is a list of other factors that also contribute to the calcium control, but we focus only on the 3 in this lecture. I don't want to make things complicated by adding this. You have less role to play compared to this one. That's why we focus more on the parathyroid hormone, vitamin D, and calcitonin. So I know you did not cover the parathyroid much in the endocrine, or not at all. So, but maybe you know that already. These are 4 glands, very small glands, sit on the posterior surface of the thyroid gland. We're talking about 5 millimeter by 5 millimeter and maybe 1 millimeter thick. A lentil size, and they are not easy to see. They also have a lot of adipose tissue. That's why sometimes it doesn't seem clear. They have capsule, which have septa extended inside this. So, because of their size, this patient that I told you in the beginning, she removed the thyroid gland. A lot of times they remove the parathyroid. They don't see. Or they cut the blood supply, and there's a lot of issues with this. So the surgeon has to be careful. This patient, apparently they removed her parathyroid. They didn't tell her, or they didn't know, they didn't see this. What the surgeon usually do, they try to dissect some of the thyroid and leave it, and a lot of time they just insert it back in the sternocleidomastoid. And you would get the blood supply, because otherwise you can't always keep, dissecting it clearly with the blood supply. If you put it in the skin, in the muscle, it will get the blood supply from the muscle, and a lot of time they put it in the forearm. You put just insert it back there. But this is a trick with the people when they come somebody like that, and actually you will see clinically people come after the surgery with this particular symptoms. So, just the digression from this topic. But you can see again, 20–40% of the stroma is made of those adipose tissues, a lot of fat, despite their small size. It's very vascular organ. This is an endocrine or exocrine gland. Endocrine gland. So expect a lot of capillaries, blood vessels. It's very small to have a duct, it's tiny, 4 millimeter or something, so you don't expect much. So, but very, very critical when it comes to calcium control. So the main cells we'll be discussing are called the chief cells, which is the cells that making the PTH, the parathyroid hormone, which is the main function of the parathyroid gland. There's more cells than the other type, and they are polyhedral, little bit eosinophilic. They're very small, 6 to 8 micron in diameter, and they make sometimes anastomonic cords. But the other things also, you might see some of those have a lot of glycogen in the cytoplasm, so they look really pale. It's kind of funny a little bit, feel as artifacts, but actually, because of that, glycogen is washed during preparation, so it has this clear area. The other type of cells called oxyphil cells, not really known what's the function, but they're way different, much bigger. They're 12 to 20 micron in diameter. They have more eosinophilic appearance, and you can see these cells will be grouped. Oxyphil cells will be different than the chief cells. But the chief cells are the cells that can make the PTH. PTH is the one that we discussed because of this. And again, the lady removed her parathyroid gland accidentally after the removal of the thyroid gland. That's why she developed these symptoms, and we know why. So we say there is organ involved in the calcium regulation. So calcium has targets. Calcium working through a receptor. It's called calcium sensing receptor. This is actually where the calcium will bind, and then we know that we have enough calcium. So the calcium sensing receptor are expressed on multiple organs, including the parathyroid gland, where we have the chief cells. We also have calcium sensing receptors in the renal tubules and the osteoclast. So there are multiple targets of the calcium sensing receptor, but the main one that react to the calcium is the parathyroid gland. We'll talk about how this also controls, see, it's also have some effect not only on the bone, but also the kidney, and there is some effect on the intestine that we'll see next week. So they're just more of a global picture of how calcium is regulated. But we'll focus on certain things for this lecture. So the calcium sensing receptor is this 120 to 160 kilodalton family, G protein couple receptors. And I asked the other students, do you know what it means? So I don't need to explain that. Highly expressed in the parathyroid and in the kidney, and it's in other places. And it is influenced by the calcium. Calcium will bind to this particular receptor, which senses the presence of the calcium in the circulation in the body. It's very tight, very sensitive to the attachment to the calcium. It's, again, the receptor is also expressed in other places like intestinal lung and so on. So the type of the receptor is G protein couple receptor, but the name of the receptor is calcium sensing receptor. It is the receptor that senses the calcium. Simple. So when I ask you a question, it's going to be calcium sensing receptor. I'm not going to ask you what the type of receptor, unless it's a different question, but usually it's the name. So the parathyroid gland, which contain a lot of those calcium sensing receptors, will be the organ basically to feel the presence of the calcium in the body and then react based on that. And this slide is really important to see how this will function. So this is one of the chief cells of the parathyroid gland. They have this structure here, which is the calcium sensing receptor. It's the calcium, the receptor that feel the calcium. Normally, we have enough calcium in the circulation to keep all these receptors occupied, like this one here. You see the calcium, which is the ligand for this receptor. This is normal. It's supposed to be like that, all of them. So when they are binding, they actually trigger a signaling through the phospholipase A, which degrade the PTH. These chief cells, the function is to make PTH, but PTH is there. If you don't need it, you will degrade it to break it down. As long as we have enough calcium binding to this receptor, the calcium sensing receptor, it will send this signal through the phospholipase, and it said we don't need the PTH, break it down, so we degrade it. But when we have low calcium level, so some of these receptors or many of those receptors will be free. We don't have enough ligand, we don't have calcium. So there are some changes that will happen to the receptor. They relax and the conformation change, shape will change. When they do that, they can't trigger the signaling mechanism, which is the phospholipase. They can't signal through the phospholipase to tell the PTH to break. So what will happen is the PTH will increase. So PTH will be released in the circulation in reaction to the level of calcium in the body. And all the time, when we talk about calcium, we're talking about this very, very small percentage of calcium. It's called ionized calcium. Not the total calcium, not the binding. You still measure this because other diseases, kidney especially, other issues with the kidney can affect how the calcium is binding to the protein. So a slight changes in the free ionized calcium, that's why it's very tight. Will trigger this right away, and then the body will start releasing the PTH and not breaking it down. Now, so what happened? PTH will be released in the circulation. So it's going to be circulating, finding some target. Those targets are called PTH receptors, PTH1 receptors. They exist on the kidney, we'll see that, but also first exist on the bone, as we'll see. So what will happen here? Okay, let me digress a little bit. So I'm going to stop here at the PTH. Now we have the calcium sensing receptor. Since there is no calcium, they change, they stop the phospholipase signaling, and PTH will start to be not degraded and be released in the circulation. We'll stop. I'm going to move to something else that we discussed last week, but not in detail, which is the remodeling. We said why remodeling happened. I said two main reasons why. Microfractures, what else?
Calcium release.
Calcium release, yeah, which we're talking about that. So these are the two main things. But again, it happens at certain areas. It doesn't happen all over the body, certain parts. We call it the remodeling site. And we said that happen both at the cortical and trabecular bone level, correct? So the first, what we call the initiation of this process, we said before, if we don't have osteoblasts active, they are formed lining cells. We said just on the surface, a flat lining cell looks like epithelial cell, endothelial cell. When this process is triggered, they actually get lifted up and form an area, they call it the canopy. They make like a cave around the area that's going to be remodeled, freeing the surface for the osteoclasts to come. Because otherwise we'll be sitting. Osteoclasts not going to come and jump on top of those. They have to be removed. So they form this area, they call it the canopy. Canopy means the cavity or cave or something where you're going to be sitting. defining the area of the remodeling. So this is the whole cavity. It's not about the osteoclast. It's the whole area. We're going to remodel this classroom. So we just close everything, all the windows, all the doors. Nobody will come in this area, and we're surrounded by sheets from outside, so nobody will come in. These are the first step in the remodeling process. This will be what triggering the osteoclast and osteoblast to come later. So how now the osteoclast and osteoblast, there must be something signal these cells to kill them after the initiation of this. This is through one major mechanism called the rank ligand OPG pathway. This one main mechanism studied, but it's not the only one. But the thing is, there's a lot of target drugs that target this signal. So the name of the rank is the receptor activator of nuclear factor kappa B ligand. It's better to call it rank ligand, not shortcut. Member of this tumor necrosis factor family expressed on osteoblast and marrow cells. So rank ligand expressed on the osteoblast and mesenchymal line versus the rank, which is the same from TNF family, but this is the receptor. The receptor exists on the osteoclast and the osteoclast precursors, monocytes, macrophages line. So this is just a structure of those, ligand and the receptor. They have extracellular, intracellular domain, and transmembrane domain. And there's something called OPG. So computer. Osteoprotogerin, or sometimes they call it osteoprotegrin. They call it a decoy receptor. Decoy receptors means fake. It will act like a rank receptor, but it's not a receptor. There's nothing there. It's empty, like blank. So we'll see how this will work. So rank ligand is the release. This will be the molecule that's going to be either expressed on the surface of the osteoblast or released. We call it the soluble rank ligand. Ligand is the molecule that binds to a receptor. As long as it doesn't bind, we don't call it ligand. It binds to a receptor, we call it ligand. And the receptor expressed on the surface of the osteoclast and osteoclast precursors. So we have a ligand, something will trigger or bind to a receptor. So the rank ligand binds to a receptor in the rank on the osteoclast will activate osteoclast. Osteoclast wants to get this message, they will start resorbing the bone, or also we can start forming more osteoclast because it gets expressed here on the precursor will join, we said the osteoclasts are multinucleated cells formed by merging multiple of those monocytes. So osteoblast and osteocytes both express the rank ligand. The receptors, the rank expressed on the osteoclast and the osteoclast precursors increase activity. What the osteoprotogerin does, it is a decoy receptor made by the osteoblast. So why we do that? Why you think we need that?
Well, to start, like the osteoclast breaks it down and the osteoblast will start feeding it.
So I don't get it.
So osteoclast has done its job.
Yes.
Now the osteoblast needs to fill it again to form new osteoclast.
Yeah, it's actually yeah, go ahead.
I think to protect themselves,
Which cells?
the osteoblasts
From what?
from the osteoclasts.
No, the osteoclast is not going to do anything to them. It doesn't break them. The osteoclast is going to break the matrix.
I think because both have the receptors, yes?
Osteoclasts only have the receptor.
Maybe it's almost negative feedback.
Yeah, kind of. Yeah, Hassan.
Yeah, the same. So for everything, you need something to regulate it. You don't want too much rank ligand working, especially for area of remodeling and maybe the osteoclast activity is done. You want now
Yeah,
more
very good. Yeah,
osteoclast.
yeah, excellent.
Or just
Yeah, so
so-
the decoy receptor, especially, I told you, can be expressed on the surface, so this can bind to this. But the one that's soluble is difficult to control. You cannot retrieve this back. They are already released. So I have to send something to make them stop stimulating the osteoclast when the work is done. So I send all this OPG, which will all this rank ligand will think, oh, this is a receptor, so we bind to it. So I just consume all those soluble rank ligand, and you can't, be any more. Then osteoclast will fade and then stop. So there's always a balance between how much rank ligand and how much OPG. So you always measure this. But this is how the rank ligand OPG pathway work in controlling bone resorption. So you can see here that the osteoblast, which is the bone forming cell, is the one that triggering the osteoclast to break the bone. So it's like we pay them to make, because they're going to get a job after that. So it's like you pay somebody to break this, or because you know what, I'm gonna come and fix it. So the osteoblast will send all this ligand to the osteoclast, so the osteoclast resorb the bone, and then they will actually come back and do the opposite. But here I just listed something. We talked about the rank ligand, OPG, but there's other mechanisms through the MCSF and WNT5, which also can stimulate osteoclast, but this is a big one and it's well known and well studied. It's also the osteoclast in the other hand will also stimulate the osteoblast to start through things like the PMP and WNT1 and SIM-A4D. There's other things that stimulate. So osteoblast will stimulate osteoclast to resorb the bone, and osteoclast will stimulate osteoblast to build the bone. So everybody, that's why they're always coupled. That's why you said before, in some of the slides I show you, you can see the section both of them together. Because they need to talk to each other. They say, okay, I'm done, you come now, or no, you start, I will finish this. So this is the kind of communication that you see. So we'll go back to PTH. We said PTH should be released from the parathyroid gland based on the lack or the shortage of the lower level of calcium in the blood. So PTH will go in the circulation, bind to receptor. We talk about the receptors here that exist on the osteoblast here and osteocytes. So when they do that, they trigger the release of rank ligand. So rank ligand will go and bind to what? The rank receptor on the osteoclast. Osteoclast will do what? Resorb the bone. So what happens when they resorb the bone? Calcium will be released. Calcium will go to the circulation. It will go and bind back to the calcium sensing receptor existing on the thyroid gland. Will stimulate the phospholipase A signaling mechanism to start degrading the PTH. PTH will never be released. We get enough calcium, we don't need you to work. That's it. Somebody can tell me the story from the beginning. Calcium. حسن.
Okay.
الحسن يعني بس هي صعبة شوي.
It's a,
مش متعود أنا عليه.
my family also calls me Hassan.
Yeah, ما بقرا يعني.
So we start, maybe we have low calcium.
No, normal calcium.
Normal
first.
calcium. Okay. So you want to start from PTH?
Yeah, go ahead. Just this thing, right?
Okay, so I have low
We
calcium.
have normal calcium. What happened?
Normal calcium. We'll have some regulation by PTH and but
Normal calcium. What does calcium do? In the
okay,
circulation?
calcium. It
What
acts-
feels the calcium?
What
senses
feels the calcium is the calcium sensing receptors.
Where they exist.
They exist mostly in the parathyroid gland and kidneys. That's where they're.
Yeah, and other places, but yeah, that's good. Yeah, parathyroid. Yeah, so.
Parathyroid. So if I have low calcium, what will happen?
No, normal calcium. What will happen?
Normal calcium,
Yeah.
I'll have regulation. Like I'll have PTH. It can be released. It can be degraded. Right?
Yeah, but they didn't say that.
Yeah. So it's
Yeah, good.
Yeah. Okay.
But will bind. So we have calcium binding
Binding
calcium
the
sensing
calcium
receptor all the
sensing
time. We have enough. So what will
Yes.
happen to the PTH?
PTH, if there is a lot of calcium binding to the calcium sensing receptors, phospholipase A2 will be activated, and then it will lead to high degradation of parathyroid hormone inside the parathyroid in the chief cells. But if there is low calcium, there will be there will be relaxed calcium sensing receptors, will lead to release of parathyroid hormone.
Why? Because of the signaling of the phospholipase is going to be
Phospholipase
there.
A2 is not
It
released,
doesn't
so
work when it's
PTH can be released.
Yeah.
Now, when PTH binds to the PTH1 receptors. They are found in the bone, they're found in the kidney, they're found in the intestine. But let's focus on the bone. They go and bind to especially osteoblasts. They want to initiate the rank L mechanism. So the osteoblast and the osteocytes, they release something called rank ligand. Rank L will bind to rank receptor, which is found mainly in osteoclasts. This will activate osteoclasts. They will start resorbing the bone. The osteoclasts also, they start through other mechanisms, they will activate osteoblasts. Now let's say that it's done, calcium is released into the blood, it will lead to lower parathyroid hormone. Also at the same time, the osteoblast doesn't want too much rank L activating osteoclast, so they will release a decoy receptor called OPG, osteoprotogerin, and that will lead to a regulation and negative feedback on rank L, maintaining a homeostatic balance.
Impressive. Why don't you finish the lecture? That's it. Very good. Excellent. I said that you have to understand the mechanism. Once you get it once, I mean, this is really going to be helpful for you in many, many cases. So, very good. Thank you, Hassan. Yeah, this is actually what he just said, some summary. Yeah, I'm happy with this slide actually, because you know what, I give it, I think it's either Gemini or ChatGPT. I told them I give them the lecture, I need some review slide, and they made it, so I just stick it. It's nice. Yes, I.
Doctor, when we said the osteoclasts, when they resorb the bone, they're going to signal the osteoblasts to build the matrix, right? But didn't we say that the osteoblasts would also signal that we want to deposit calcium? So they would take calcium from the extracellular matrix also, or the extracellular fluid.
Yeah, but the calcium, we said calcium in the circulation and also in the extracellular fluid surrounding them. And so when they need, they have to mineralize. So that's why you have to have enough calcium in the circulation. It's not always, doesn't mean that all the calcium has to bind to the receptor. If it is free ionized calcium, they take it and deposit it there. As long as you have enough calcium filling all these receptors, then nothing's going to trigger the PTH. If you need something to rebuild the bone, if you don't have, but normally you have enough calcium in the circulation not only to cover, but also to make this kind of a normal remodeling. The problem we'll see in some diseases what happened with this. So just wait until the next lecture after, because I don't want to be pushing too much. But yes, it was fun. So this just again the review slide. You might start with this actually to just put things together that you see okay changes the calcium first affecting PTH release from the gland and then binds to the bone and so on. So he already did the review, so I don't need to do that. So we need to discuss a couple of things next. So how was the class resorb the bone? So we said we have two components of the bone. We have organic and inorganic component. The inorganic component is called what?
Hydroxyapatite.
Hydroxyapatite, what's made mostly of? Yes, so in how the osteoclast resorb the bone, in the first, we said that I think the resorptive machinery, first they have to make this ruffle border. If you look at the histology, if you see an osteoclast sitting on the surface and you don't see this ruffle border, it means not really active yet. You have to see a ruffle border. The presence of the ruffle border tell you the activity of the osteoclast is happening. So the first thing is going to be the sealing. You say the osteoclast have to close the area where you're going to be working like the labor when they do work road construction or something. This is through this mechanism, which is the alpha V beta 3 integrin. You remember integrin was kind of those adhesion molecules that we discussed earlier in the epithelium. They bind to phytonectin receptor which exists on the bone surface. So there's a locking mechanism, but the osteoclast really lock itself in the place and they seal this area so nothing's going to be leaked out of this. And what's this cavity here where the osteoclast sits? House of cocoon, yes. And also one of the activity, you can tell you with osteoclast active, we can see they're sitting in this hole. House of cocoon, and you know that we're just absorbing this bone. So the ruffle border will even increase, all these foldings of the membrane will increase, and this will be the surface where they secrete all these components to degrade the matrix. So inside the osteoclast, the enzyme called the carbonic anhydrase 2, which will break down generating those hydrogen ions. I said before in the very beginning of the histology class that we need acid to break the bone, because acid will degrade any minerals. So if you take a piece of bone and put it in an acid, and this will process the bone to better for H&D essentially. You can put it in an acid for a couple of weeks, and then it will soft, it will be like a rubber. Why? Because all the minerals are dissociated, it's only organic now. So the osteoclasts do the same thing. Hydrogen will be released through this hydrogen ATP pump because the breakdown of the carbonic anhydrase will release some proton. The hydrogen will be pumped inside the resorption cavity in the Hausch-Lacouni, and this will start degrading the hydroxyapatite. In exchange, because we also have bicarbonate start to leave because the presence of those hydrogen pump will change in the acidic environment of the cell. So we have to kick the bicarbonate out, but in exchange we could get chloride back, and then the chloride will go inside actually the resorption lacunae through the chloride C7 located at the ruffle border to be pumped inside the resorptive pit. This is not to neutralize the acidity. The chloride basically to control the negative charge and positive charges, electronegative control. Because if you keep pumping positive ions inside the pit, it will stop after a while. It cannot take anymore. Then the resorption process is going to stop. So you have to have this chloride just to neutralize the electricity inside these powders. So this is how you break down the mineral first, and then what we end up with the organic component. The organic component, yeah, Jawad Zarif stuff. Jawad Zarif was a famous guy. I mean, look him up. He was the foreign minister of Iran. He was a very smart guy. So he's only Jawad I know. That's why I knew. So the organic matrix. I read a lot of history. And I used to. My dream was to be a history professor, not science. So the organic matrix will be degraded by this cathepsin K and MMPs, which is matrix contain proteins. Some enzymes will break down. So what we have in this first is going to be sealed, nothing's going to be leaked. Especially acidic environment, we don't want this to be leaked outside. That's why it's very tight sealed. Everything else will be trapped inside this cavity. We break everything. This way, the construction worker, if they really care inside the house or something, they close the whole thing, by the way. They don't close only the area they work, even outside, because the dust will fly. So here everything is closed and trapped inside this house lacunae. But what will happen after that? So it's important. Now we're breaking the mineral components by the acid, but then we'll break the organic component through the enzymes, cathepsin K mostly, and MMP, matrix metalloproteins. Now all these pieces are broken, all this broken stuff exists there. We have to transfer it. We're not going to leave it like that.
So can we say that the optimal pH for cathepsin K and MMP9 is also acidic?
Yeah, they need to. I'm not sure if they have to be that acidic to work, because they have also, you know, after a while you stop, I think, the breaking and then you start working. So I'm not sure the acidity continue, because I don't think you start pumping hydrogen when the enzymes start working.
Also, it's not
But it could be, yeah, it could be. I need to check this out. That's a good point, yeah. So what will happen to all these contents? You have to transfer it, and this area is already sealed. So they actually transfer it through the cell, transcytosis. They pack those in small vesicles at the membrane, and they shoot it to the other side, which is facing the marrow. So it will go back inside the interstitial fluid, interstitial tissue, or connective tissue, which is the bone, or back inside the circulation. So here we talk about calcium, correct? So the calcium will be packed and then sent, and go to the circulation, that's not. But we'll talk about the other components also in a different lecture. All this stuff is going to be clear, you know, also the organic components, and actually there is a way for you clinically to detect this and know what happened in the bone as we see in the short period. So the transcytosis end up with all these products will be transferred to the other side of the cell. Okay, this is summarizing the bone resorption, attachment, acidification, and demineralization, matrix digestion, and transcytosis, and then release of cells. Now we said also kidney controlling the calcium. Why? Because PTH is released, work on the bone, but also work in the kidney. So why on the kidney?
Calcium reabsorption.
Reabsorb calcium from the
Yeah, they retake the calcium there. Because yes, you look at the water in the house and you find out we're running out, whatever this beer or whatever you have in the home. Some money, whatever this container you have the water. And you're running out. So a couple of things, you try to see, oh, maybe you have some storage somewhere for drinking. But also you start to stop the waste until you see how can you fix this problem. So ask the kids, don't take shower, nobody wastes. So the same thing with the kidney. You can say, okay, you know, we lose a lot of calcium, so we'll just take it back because we need this back in the circulation. So this also through PTH, which will work through here in the two positions in the kidney, the thick ascending limb through LA, which you covered this kidney, I think, before. And so what will happen is, this is the renal cell, and this is actually the blood, and this is supposed to be the urine. So this will be the PTH1 receptor, PTH binds to the receptor, and then what it does in this mechanism, it will actually increase calcium reabsorption through what we call paracellular mechanism. So you remember the all epithelial cells have to be adhered through this just to close in one of those. So we make it actually a little bit loose. So the calcium go next to the cell, between the cells inside, back inside the circulation. This is called paracellular permeability. But the other mechanism is through the distal convoluted the tubule. Again, the calcium, the PTH will bind to the PTH receptor, but it's more active. You know, through cyclic MP will actually make this channels called TREP-V5 will open, and this will let the calcium go intracellular in this case. And then will be bind to this what we call calbindin, which is calcium binding protein, which is this one here, which will transfer the calcium, carry the calcium all the way to the blood site, to the circulation, then will be pumped back inside the circulation through active mechanism to the sodium calcium exchanger, the NCX1, or the other exchanger, which you call the PMCA, which is a calcium ATPase pump. Okay, so to summarize this lecture, changes in the calcium, lower calcium will trigger this calcium sensing receptor to feel there's no calcium. PTH will be released. PTH will work in two organs, on the bone and in the kidney. And the bone is going to be through work on PTH, a receptor through the stimulation of rank ligand for osteoclast and osteocyte, stimulating osteoclast by binding to the rank receptor. In the kidney, will work on the distal convoluted tubule and whatever the other one is sending them to finally either paracellular mechanism or active mechanism. Okay? And this will correct the calcium. Somebody can summarize this quickly because I have a couple of slides I need to discuss. Anybody, Khalid? Khalid will be here.
So I had a question back on summarize the course.
Can you say that first? Well, you can ask it this way.
Summarize the whole thing.
Yeah, just briefly like that. I just want to make sure you get the whole picture. Calcium changing, what happened?
So first, if we have less calcium, more receptors are free. So these free receptors change their shape, stop the signaling process. Then more PTH is released because less degradation. After PTH is released, acts on bone and kidney. On the bone, it binds to the osteoblasts to release RANKL. This RANKL activates osteoclast to resorb the bone. Also, it acts on the kidney by binding to the thick ascending and distal glucohandling, which reabsorbs calcium. By the
Through different paracellular. Very
No, I had a
good.
question
Yeah, go ahead.
for the kidney. So
We'll talk about the kidney more next lecture, so I'll give you more detail. I'm just giving you a piece at a time, so there's gonna be more control of this. Yeah, ask the question. It might not be. I can wait until next week.
does the calcium get reabsorbed because of the positive repellent?
No, it's an active mechanism. So they open this certain channel, TREP-V5 or paracellular.
Paracellular is because of the positive repellent, it's active.
No, it's just it's a concentration gradient. Yeah, so this lady that we talked about in the beginning, what happened to her? What happened? She removed the parathyroid, so what do you expect?
No calcium.
So we have guys.
That's why.
Because there's no calcium.
She doesn't have PTH. Yeah, that's why she can. Yeah, and that's why it's emergency. It could happen. There's other things that we talk about controlling calcium, but the PTH is really happening quickly, and you need something else because it's very tight. So you need to do that fast. So PTH will be released. That's why she went to the emergency because of this nothing. The PTH couldn't do anything. There's no PTH. So a couple of slides at the end, which is more clinical. So the bone diseases, I talk about osteoporosis. Osteoporosis is something that you need to know because no matter who you are, you're going to be a family physician, you're going to be internal medicine, you're going to be a rheumatologist, you're going to be an orthopedic surgeon, you're going to be OBGYN. You always see people with osteoporosis, and you have to be careful how we deal with this, especially with certain medication. Osteoporosis is a very common, the most common bone disease, and we said before, you start losing bone. Bone resorb, as you see in this mechanism, and do not bring any more back. So you end up losing bone over time, and you can see this picture compared to the one that's a normal trabecular bone versus the osteoporosis. You can see how thin this thing, and they're disconnected. So all this supporting of the trabecular bone is going to be lost, and they told you this is the metabolically active site. So things like the vertebra, this is the patient, the same patient, vertebral fracture. So you end up with the fracture because the vertebra, I told you, if you look at the X-ray carefully, the cortical bone is very thin. That's why, yes, you can also break your hip, femoral hip or something because of this, but usually it's a very advanced case. Usually it develops this before. Because the trabecular, the bone of the vertebral body have a lot of trabeculae mostly. So, and all this activity happened in the trabecular first. We're still getting remodeling in the cortical bone. So you lose cortical bone, but on a much lower base. So by the time you get this, so if you get somebody do still CT scan, and you see the cortical porosity, a lot of holes in the cortex, because this is where the osteos are. You don't also rebuild very well. You end up with holes inside. This is a really bad sign. This is way better, worse than we think. So That's one thing about the osteoporosis. The other things about, which is the balance between the different areas. Bone metastasis. I mean, I always bring this because this is my field of research since the last 30 years. So usually you develop what we call osteolytic metastasis. The cancer cell, when they go there, by the way, in cancer patients die because of the metastasis, not because of the primary tumor. Most of the time you can remove it, even if you don't. It doesn't spread, it'll be fine. But once you develop metastasis, they die. It's a very advanced state. That's why you stage the cancer. Look at the lymph nodes, how far. Anyway, but the bone metastasis, the cancer cell goes there and they actually trigger. They play through this rank ligand OPG mechanism and they keep feeding the osteoclast as if they are stimulated that they need to work. So the osteoclast keep chewing the bone. But there's a big hole in somebody's humerus. Huge. This will just push him like that and she will fracture or he will fracture. Because they're getting very aggressive. And those patients go to the emergency because of what we call hypercalcemia of malignancy. They release calcium like crazy. I mean, you can imagine all these pieces of bone are gone. There's a lot of calcium in circulation. End up with opposite to the other case, hypercalcemia. Because now there's too much calcium regardless of how they're, even if you inhibit pH, it's just calcium is out of control. A couple of drugs that control this mechanism, denosumab is one of the drugs. I think it's called class on the market. But this drug came because it's actually similar to the OPG. It's an antibody that binds, the ligand binds to it, so it can prevent the activation of osteoclast, so inhibit. He uses it in cancer, and the funny thing, because I was working with some of the companies a long time ago when they developed this, they changed the name because they used to be cancer drug. So they said, okay, use osteoporosis or a smaller dose. And they give it to the patient. The patient started to refuse. You give me a cancer drug. So they changed the name. It's the same drug, it's just different dose, yes.
Yeah, with denosumab, wouldn't it also affect the other bones? So like if a patient had a tumor in their femur, wouldn't it also affect like their other bones, like the humerus, the scapula, the ribs?
How's it gonna affect it?
Like it would affect their ability to like to regenerate, to grow and to form like newer osteols and all that.
No, it will stop the resorption process.
Yeah. Will it stop the resorption process in the other bones as well? The
Yeah,
bones
if
that are
it's
not
systemic
affected?
disease, yes, systemic drug.
If it's systemic, then
Yeah, but you know, this is side effect. Yeah, this is side effect, and they develop what we call atypical fracture. This is side effects of long-term use of some of these drugs. So they give them holidays every once in a while. It's more complicated, but yes, it is because you can affect, yes, because we need the normal remodeling process. It will stop it, but it doesn't kill it. But with those patients with cancer or osteoporosis, the benefit that you can get from the drug is way outweigh any side effects that might have. The other drug is called bisphosphonates. This is actually the older drug than the denosumab. They started giving this in the mid-90s. So they actually poisonous to the osteoclast. Basically, they get absorbed and deposited in the bone itself. And then when the osteoclast starts to absorb, they basically die. It's like a rat poison or something. They get them in this thing. So just give you an idea how this actually all interact together. So next week we'll have talking more about vitamin D calcitonin. Thank you. Thank you guys. Now I'm gonna get used to this. Thank you.